Today we have the Marshall Lecture and the awarding on the Young Economist Award for 2017. So it's a very good day. Also, it's a good day because the strike that was supposed to occur has been cancelled. So whoever needs to fly out today can relax. So the first thing we do this morning is indeed to announce the winners of the Young Economist Award. And I would like to call Estelle Cantillon and Silvana Terreiro on the stage. Estelle and Silvana, as you know, are the program chairs of this year's conference for the EEA part, and they've done an amazing job. So first of all, I want to continue thanking them. We've been thanking them more than once. And they have also been part of the selection committee for this award. So please.
Thank you, Eliana. Good morning, everyone. I'd like to start by saying a couple of words about the Young Economist Award. The award is given every year to 3 outstanding papers presented at the EEA contributed sessions by young economists. Young here is defined as anyone within 3 years past his or her PhD defense. Until 2015, the prize was known as the FIEM Award and sponsored by the Fondazione Enrico Mattei. And since 2016, the sponsor is UniCredit and Universities Foundation, and thanks to their support, each winner receives 3,000 euros. On behalf of the European Economic Association, I'd like to thank the Foundation for their generous support. This year, a committee composed of Giacomo Ponsetto from CREI, who is representing UniCredit and Universities Foundation, Estelle Cantillon and myself were in charge of selecting the papers. We had 459 papers submitted for the award. We made a first selection among the papers receiving a grade of A- or more. 13 papers were shortlisted, and after careful consideration and discussions among ourselves, we came up with the 3 winners. So Estelle will now announce the winners.
All right, so I'm going to name the winners in alphabetical orders. When you hear your name, I will invite you to come to the stage, so to get ready for the next stage. So the first winner is Stephane DePaz from Columbia University and moving to Bank of France for a paper called A Kinked Demand Theory of Price Rigidity. So let's just give him a round. So if Stephane can come. And so just a few words on the paper. So the paper, by the way, is going to be presented today at 2:15. So if you, in the macrofinance and monetary policy session. The paper, so as you all know, nominal rigidities are the core of Keynesian models. They're the main friction that makes money non-neutral and allow monetary policy to affect real activities. But so what this paper does, it's provide micro foundations to these nominal rigidities. So by revisiting the old rationale, I'm sure you all know, I'm not a macroeconomist, but I know about the kinked demand curve. So the fact that we have a kink in the demand faced by firms, because when a firm raises its price, it's only its customers that see this, and they're going to decrease their demand for the product. When the firm decreases its prices, it's not as well known by the other consumers not currently consuming these products. So what Stephane does is that he puts this mechanism embed this in a macro model and sees first that this is not enough, it's creating a multiplicity of equilibria, and he proposes an equilibrium selection mechanism and then derives, shows that this is a force for price rigidity, but also derives new predictions, testable predictions that arises that other theories could not explain and that are consistent with the data. So good paper, very nice paper. All right. So our second winner is Matteo Gamalerio from the University of Warwick for a paper called Fiscal Rules and the Selection of Politicians, Evidence from Italian Municipalities. And a few words on the paper. So we all know that we need good politicians to have good government. Okay. So and what the paper does is that it's exploiting a policy change in Italy that. Basically, what happened in 1999, there were new fiscal rules in Italy that restricted the budget deficits that municipalities could have. And then in 2001, these restrictions were lifted for smaller municipalities. So what Matteo exploits is this policy change to see what happens in terms of entry of politicians, entry of citizens into politics. Okay, because it's not only looking at what happens in terms of what they do, but how does that affect incentives for people to stand up and become politicians? And what he sees is that this reduction in the level of discretion that politicians have actually decreases the quality of politicians that enter politics. And so it shows it's an interesting trade-off between the quality of the political class. It's a trade-off between when you reduce local politicians' policy-making discretion, it reduces the externality from budget deficits in municipalities, so that's a good thing, but it also reduces the quality of politicians. Okay, so again, very nice paper. So the paper was presented yesterday, unfortunately, so you should have seen before. So our third awardee is Petra Diamond from the University of Southern California, moving on to the University of Lund in Sweden for a paper called Does Teacher Sorting Across and Within Schools Explain Inequality in Education Outcomes? So in short, so you've got the abstract here, but so I'm sure you all know that inequality of access to educational opportunity is an important concern in all developed and also developed economies, but I mean everywhere, because it affects economic opportunities and social mobility. And it's well understood that there's the sorting of students to schools and sorting of teachers into schools are two of the drivers of this existing inequality of educational outcomes. So what the paper does for the first time in a unified setting is to integrate these both the classic determinants of individual education performance, for example, student and school characteristics, but also sorting both of teachers and students into schools. It's to do so, it's actually extending a technique that was developed by Abode, Kramartz, and Langerman in a paper in Econometrica to study assortative matching in the context of labor markets. And what it finds is that when you compare them in the unified setting is that you see that on average, student sorting is a more important determinant of inequality than teacher sorting, but that's not true in rural areas. So what's interesting is that in rural areas, the opposite is true. Teacher sorting is a bigger driver of determinants of the difference in individual education performance. So congratulations. Very good, very nice paper. All right, so now I'm going to invite Gian Antonio Deroni, Secretary General of the UniCredit and Universities Foundation, to come on stage to give you the awards. You should probably move on a bit more center stage. Yes, sure.
Okay, now we move on to the lecture, and it's a real pleasure to introduce Amy Finkelstein. So Amy is the John and Jenny MacDonald Professor of Economics at MIT. She's also Scientific Co-Director of JPAL North America and Co-Director of the Public Economics Program at NBR. Amy has received numerous honors and awards. Let me just name a few. She got the prestigious Clark Medal in 2012. She got a medal from the American Society of Health Economics in 2014, and the Elaine Bennett Prize awarded by the EEA in 2008. She received her PhD from MIT in 2001, then joined NBR and the Harvard Society of Fellows, and was finally hired back by MIT, where she's been since then. The core of Amy's research is insurance markets and healthcare, and that's what she's going to talk about today. She has addressed really fundamental issues in this area. For example, the role that asymmetric information plays in leading to inefficiency in insurance markets. Also, how social insurance programs affect healthcare markets, and what determines innovation incentives in healthcare. Amy's work is mostly empirical. However, it's strongly motivated by theory. So the types of tests that she has decided shed light on competing theory and uncover patterns in the data that provide new starting points for theory to advance. So let me just give you a quick example from Amy's early work, which was trying to understand how asymmetric information in insurance markets affect the behavior of buyers of insurance as well as insurance companies. Now, standard theory would predict that those who have greater insurance coverage should generate higher losses, either because of the adverse selection or moral hazard. Yet, if you look at the empirical evidence that had been accumulated up to until Amy's work, those studies did not really find a coherent pattern in terms of correlation between coverage and losses. Now, Amy, in joint work with Kathleen McGarry, has come up with this idea that indeed people differ not only in their risk types, but also in their risk aversion. So there's two dimensions of private information. And when you take this into account, what happens is the holders of insurance policies don't necessarily have a higher rate of claims, because it will depend on the correlation between the risk aversion and risk types, and also on the relative importance of the two. So this is kind of a really simple but key idea that can explain a lot of puzzles, but also lead to advancement in our policy, in a sense. Now, if you look at Amy's CV, it's really an embarrassment, not for her, but for those who read it. There's a very long list of publications in top economic journals, but also in journals like the New England Journal of Medicine Science, which shows how her impact has gone beyond the Economist's community. Her first scholarly contribution can be traced to first grade. I've done a little research. And at the age of 6, I believe she had to write a report on mammals, and she chose to write it on elephants. Now, she enjoyed that endeavor so much that apparently 1 week later, she wrote a second report, not required by the school, on alligators. And she decided to make this a comparative study. So every page would start with, differently from elephants, alligators, ... Now, Estelle and I have been trying to rehearse memories of when we were in grad school, and we both very clearly remembered the year in which Amy was applying for PhDs, and she had been admitted both at Harvard and at MIT. And the head of admissions at Harvard was really keen on getting her to come to us. So we had been tasked, to convince her to come. And as you can see, we had failed because eventually she joined MIT. At the time, we were a little disappointed. But We didn't know that Harvard had won a much tougher battle 5 years later, because apparently when she was in high school, Amy used to earn money by juggling at birthday parties, and she was so good at it that she seriously considered going to clown college instead of going to Harvard. So we don't have a counterfactual of what her contribution to individual happiness would have been in that case, but we know that luckily for our profession, she decided to be an economist. So it's a pleasure to hear Amy talk about moral hazard in health insurance. And Amy, you have 1 hour for your talk.
Eliana, thank you very much for that overly generous introduction. I'm sorry I didn't actually prepare to discuss alligators and elephants, but I think I remember some of the key differences if anyone wants to discuss it afterwards. All right, so as Eliana said, I'm going to be talking today about moral hazard in health insurance, both what we know and probably more importantly, especially for those of you in the audience who aren't, have the misfortune of not being completely fascinated by the subject of US health insurance markets, how do we know it? So very broadly, the sort of theme of this lecture is the complementarity between empirical methods. Very broadly speaking, I see two vibrant strands of empirical work in applied micro these days. One is the so-called credibility revolution in economics, which emphasizes the value of research designs to produce compelling evidence of causal effects of behavioral responses. And the second is the so-called structural modeling, which emphasizes defining and estimating economic objects that can be used then to predict behavior in counterfactual environments. These are usually pursued independently or viewed as substitutes. And so the theme of this talk, which hopefully is not particularly novel or controversial, is that there can be important complementarities between these two approaches. And I'm going to discuss this in the particular context of an area that I've been working in for many years, which is consumer cost sharing in health insurance. And since my examples are all going to come from the United States, and there are some idiosyncratic features of US health insurance contracts and health insurance markets, I just want to be very clear on what we mean by cost sharing, since I'll be talking about it throughout the talk. So the first thing to know, and this will come up in several places, is that health insurance contracts in the United States are annual, so they reset every year, and they have cost-sharing features which determine the out-of-pocket price for healthcare that the consumer has to pay. So what I've graphed here is just a sort of stylized typical contract. On the x-axis is total medical expenditures during the year, and on the y-axis is the amount that the individual is paying out of pocket. And the typical contract is nonlinear. It often starts with a deductible. I've shown a $500 deductible here. In the deductible, you face an 100% out-of-pocket price. Every dollar of medical spending translates 1 for 1 into a dollar of out-of-pocket costs. Then there's often a coinsurance arm of, say, for example, here, a 10% coinsurance rate, whereby for every dollar of medical care, the consumer pays 10 cents out of pocket. And then eventually, if you spend enough during the year, you hit a stop loss. Here, it's $3,500 in out-of-pocket spending. Once you've spent that much during the year, the rest of your medical expenditure for the year is free. There's a 0% coinsurance. And then, of course, when the next year starts on January 1st, the contract resets, and you're back in the deductible. So why are contracts designed this way? Well, it's the sort of classic trade-off or tension in designing insurance products between wanting to provide insurance or risk protection so that individuals can smooth their marginal utility of consumption across different states of nature, and the incentive properties when individuals no longer face the full consequences of their action. More consumer cost sharing, higher out-of-pocket shares, reduce the risk protection. They expose the consumer to more risk, but they give them more skin in the game, so better incentive properties in making their healthcare decisions. And so in trying to think about the optimal health insurance contract and how to strike the balance in this cost sharing, one of the key empirical questions is, well, how actually does consumer cost sharing affect healthcare spending? And that's what I'm going to be talking about today, and in particular, as I mentioned, emphasizing how have we tried to answer this question. And so just to give away the punchline, it's going to be that these reduced form and structural approaches are both valuable and they're highly complementary in ways that this talk will try to illustrate and make precise. Just a brief note on the use, or I should say abuse, of terminology before I get started for you contract theorists in the room. What do we mean by moral hazard in health insurance? So the general definition dates back, as far as I know, to Arrow's seminal 1963 paper, which effectively invented the modern field of health economics. He talks about many things in that paper, one of which is moral hazard, and he describes it as the responsiveness of healthcare spending to insurance coverage. And perhaps the canonical theoretical example of this, a sort of classic hidden effort problem, is drawn out in theoretical work by Ehrlich and Becker, where they talk about how if you have health insurance, you're no longer exposed to the full consequences of your decisions, and so that will affect your unobserved health investments. You're going to eat more cheeseburgers, smoke more cigarettes, exercise less. You're not actually giving me the 10-minute warning, are you? Okay, just checking. In practice, however, empirically, the working definition in the field of health economics has become how healthcare spending conditional on one's health responds to consumer cost sharing. In other words, the price elasticity of demand for healthcare, taking your health as exogenous. So you might ask, why is this considered moral hazard or a hidden action problem? Why not think of it as a hidden information problem? I think there's some merit to that. As I said, this is how the term has commonly been used or abused in the health economics literature, so I'm going to continue in that tradition. I will note for you purists in the room that we can also appeal to Milgram's sort of classic result that you can rewrite any hidden information problem as a hidden action problem, and therefore we don't have to worry too much about this terminology going forward. But I just do want to be clear that what we're talking about as health economists when we talk about moral hazard in health insurance is how, given a health shock, how you make your healthcare consumption decisions given the out-of-pocket prices you face. So I want to talk about three main things in the talk. The first, starting from the beginning, is existence. Moral hazard in health insurance does exist. Again, I'll give away the punchline, but how do we know it? And then if you want to move beyond just testing to actually quantifying, the first question comes up is the nature of that moral hazard. And in particular, if you think about that nonlinear contract I showed you earlier, how do individuals respond to that nonlinear contract? Do they take into account the dynamic incentives embedded in it in making current healthcare decisions? And then once we've done some work on that, what are the implications? How do we use our estimates to forecast health insurance spending under alternative contracts that are not seen in the data? And then I'll return at the end, hopefully, to sort of wrap this all together to talk about some of the key values of reduced form evidence, the key values of economic or structural modeling, and some of the important complementarities between them. The final thing I just want to say by way of preliminaries is that while I'm the one standing up here today, I'm going to be presenting a lot of work that I've done, and it's been done with many collaborators. I particularly want to note that for the work I'll be showing you on the Oregon health insurance experiment, I've been leading that with my co-principal investigator, Kate Baker, and a very large team of researchers and other partners in academia, in the hospital system in Oregon, and in the state government in Oregon. And then when I show you the work on spending responses to nonlinear health insurance contracts, this is based on multiple papers, all of which were done with my long-term collaborator, Laurent Enav, and several other collaborators on specific papers, Aviva Arendine, Mark Cullen, and Paul Schrimpf. All right, so let's jump into the substance of existence. Does moral hazard in health insurance exist? Well, as we've just talked about, health insurance by design reduces the price that individuals pay for their medical care. And so Economics 101, or 1401 as we say at MIT, will tell you that demand curves slope down. So if you lower the consumer price of healthcare, that will create higher healthcare spending. So, we sort of know from theory that moral hazard in health insurance should exist. I should note, however, that there are, despite that basic theory, competing points of view out there. One is that moral hazard does not exist, and so this has been articulated, I think, most publicly by an influential article Malcolm Gladwell wrote in The New Yorker in 2005 called The Moral Hazard Myth, so the title in some sense says it all. And the idea, as this quote says, is we go to the doctor grudgingly only because we're sick. In other words, this is the argument essentially that the price elasticity of demand for healthcare is zero. it's a necessity that is not responsive to price. There's also a view that gets a lot of attention in US healthcare policy discussions that actually health insurance, far from increasing healthcare spending, may decrease healthcare spending. And the idea is that by improving one's health and by allowing for more efficient care, we can reduce healthcare spending. And sort of a key notion in this is that in the US at least, by law, hospitals have to treat patients who come in through the emergency room, whether or not they can pay, but they don't have to treat non-emergencies and you don't have to treat primary care. And so one of the big arguments for expanding health insurance coverage, as was done under Obamacare or the Affordable Care Act, was that by covering the uninsured, we could get them out of the high-priced emergency room into primary care and perhaps reduce certainly emergency room spending and hopefully overall healthcare spending. And so here's Governor Rick Snyder of Michigan announcing an expansion of health insurance under the Affordable Care Act, articulating that view. So we have everything from economic theory saying health insurance should increase healthcare spending to it won't change healthcare spending at all to actually it's going to decrease healthcare spending. So how do we move beyond these rhetorical claims to actually get at this empirically? The obvious empirical challenge, of course, is that people who select different health insurance plans are going to do so in part based on their expected healthcare spending. That's the standard adverse selection arguments of Akerlof and Rothschild and Stiglitz, so that when we see that people in more generous health insurance plans have higher spending, we don't know if that's selection or moral hazard. Fortunately, we have compelling reduced form evidence that health insurance does in fact increase healthcare spending, and I'm going to briefly describe just a small portion of that evidence, results from 2 randomized evaluations, and then some quasi-experimental evidence from the bunching literature, which I'll then use in the rest of the talk. Randomized evaluations obviously solve the causal inference problem that I just mentioned. By randomly assigning insurance contracts across individuals, we ensure that by construction, on average, the individuals with different health insurance contracts are identical in all ways except for their health insurance contracts, and therefore we can attribute any differences in outcomes like healthcare spending to individuals with different health insurance to the health insurance per se, because we know that otherwise they're on average identical. There have been 2 major randomized evaluations of the impact of US health insurance coverage. One is the Oregon Health Insurance Experiment, which, as I mentioned, I've been leading with Kate Baker, and the other is the RAND Health Insurance Experiment from the 1970s that Joe Newhouse from Harvard is the principal investigator on, and that actually occurred back while I was doing my early work on alligators and elephants, so I was not actually involved in that study, but I wanted to show you some results from it anyway. Just to tell you briefly about the Oregon Health Insurance Experiment, Oregon, like many states in the United States, has a Medicaid expansion program. So Medicaid is public health insurance for low-income individuals, and the standard program requires that you meet not only financial requirements, like you're poor, but also certain categorical requirements. You have to be in a particular category, such as being a child and poor, or being a disabled adult and poor, or being on cash welfare and poor. But Oregon, like many states, had a program to cover people who were financially eligible for Medicaid, but not categorically eligible. So think low-income, able-bodied, uninsured adults. They had closed this program to new enrollment from 2004 on due to budgetary constraints. But at the start of the 2008 biennial budget cycle, they realized they had enough money to reopen the rolls. They also realized they didn't have enough money to cover everyone. They estimated that they had money to cover about 10,000 people, and we've subsequently estimated there are about 200,000 people who would meet the eligibility requirements. And so they decided, actually without any input from researchers, that the fairest thing to do, rather than first come, first serve, which would privilege people who were more on the ball, might not be as needy, was to run a lottery. And so that's literally what they did. They ran a big public relations campaign with ads on buses and healthcare clinics, on the radio, urging people, if they were interested, to sign up, and then they randomized. They randomly selected names. About 75,000 individuals signed up, and in the end, 30,000 were randomly selected to be able to apply for Medicaid. So what you won if you won the lottery was the ability to apply for Medicaid, and then if you met the criteria, get in. So in our work, we're going to use the lottery as an instrument for Medicaid coverage. All the results I'll show you will be IV or late estimates. To give you a sense, the first stage of the impact of winning the lottery on Medicaid coverage is about a quarter. So that's how we're going to scale them up. What you won if you got on Medicaid is is a health insurance product with zero consumer cost sharing. All healthcare services are free for the Medicaid enrollee. That includes not just doctor and hospital, but prescription drugs, et cetera. This is a long and ongoing project in which we've looked at many things, not just healthcare use, which I'm going to show you today, but also health and economic security. And so all of the papers, as well as the underlying data, if you would like to go play with it yourselves, is available on our website. So just to very briefly show you some results, the first thing I'm going to show you is contrary to the aspirations of many health policy advocates, far from decreasing emergency room visits, getting people out of the emergency room, Medicaid increases emergency room visits. So what I'm showing in dark blue is the control mean. Those are people who lost the lottery. And in light blue, the control mean plus the IV effect of Medicaid. So I've just added the IV estimate so you can see the difference, and then the 95% confidence interval with the Wicker plot. And if you look, for example, at the number of emergency room visits, you see that Medicaid increases emergency room visits by about 40% in the first 18 months of coverage. Now, one reaction to that is, well, maybe people go to the emergency room when Medicaid makes it free because they can't get into primary care. That turns out not to be true. Medicaid increases healthcare use across the board, not just emergency room use and hospital use, but any outpatient visit, and also a bunch of preventive care, like having a mammogram screen, your blood sugar tested for diabetes, your blood cholesterol tested. So what we see here that health insurance increases healthcare use from this experiment. The RAND health insurance experiment shows something similar. This was an experiment designed to study the effect of consumer cost sharing on healthcare spending, and they randomized 2,000 families in the 1970s across plans with different consumer cost sharing. Now, as I mentioned, real-world plans are nonlinear, have these nonlinear budget set, and the RAND experiment followed that in that tradition as well. So all plans limited participants' financial exposure. They had a stop loss or a maximum dollar expenditure for the year, above which individuals face no cost sharing. And what they did is randomly assign families to plans with different initial consumer cost sharing, including zero, so that would be full coverage or the free care plan, 25%, 50%, or 95%. And then within that, they randomly assigned different stop losses within each coinsurance arm. So for example, you could be randomized into the red line, which is a 25% coinsurance up to $1,000 out-of-pocket maximum. You could be randomized into 50% coinsurance with the same $1,000 out-of-pocket maximum, or a 25% coinsurance with a lower out-of-pocket maximum. And what we see, once again, if you just look across people randomly assigned to different coinsurance arms, is that higher consumer coinsurance lowers healthcare spending. When you have to pay more out-of-pocket, you use less healthcare. So relative to this is the free care plan, you can see as you increase the coinsurance arm, annual healthcare spending goes down. All right, the final example I want to give you, hopefully you're already convinced that we've rejected the null, but this one will come up a lot in much of the rest of the talk, so I want to go through it a little carefully, is applications in the Medicare Part D program using these bunching estimators, which are increasingly being used in public economics to analyze bunching at kink points in convex budget sets. They've been used in a lot of cases, income taxes, pensions, et cetera. I'm going to use it in the context of Medicare, which is the public health insurance, universal public health insurance program for the elderly in the United States. And I'm going to focus on Medicare Part D, which is the part of the health insurance plan that covers prescription drugs for the elderly. This is the newest part of Medicare. It was introduced in 2006. It has about 32 million enrollees, and it's about 11% of Medicare spending. And the typical coverage is highly nonlinear, but in a somewhat idiosyncratic way that the US Congress, paying, I'm sure, close attention to optimal insurance theory, saw fit to design. So let me just describe it to you because it's going to be the focus of what I'm showing you in a lot of what follows. Again, there's a deductible. The first 200, this is a standard contract from 2008. We're showing, again, total expenditures for the year on the x-axis and the share pay, or the amount paid out of pocket on the y-axis. So there's a deductible in which there's 100% coinsurance. You're paying dollar for your medical care. Then there's a 25% coinsurance arm in which for every dollar of expenditure, you pay 25 cents out of pocket. And then when you hit this in 2008, $2,510 in total expenditure for the year. You enter the famous gap or donut hole in Medicare coverage, in which you go back to a deductible range. You now are paying dollar for dollar on the margin. So the key is that the price of healthcare becomes discontinuously larger right at this kink point, and then if you spend enough, you're back in the catastrophic range. And so, standard economic theory says that with convex preferences smoothly distributed in the population, you should see bunching at this convex kink point in which insurance becomes discontinuously less generous on the margin. The out-of-pocket price rises sharply. And in fact, that's what you see if you just plot the data. So this is just the histogram of prescription drug spending for Part D beneficiaries in 2008. The kink was, I said, at $2,510, and you see excess mass there. If you think that perhaps Congress, in its infinite wisdom, happened to place the kink point at exactly where there was excess mass, they've been kind enough to change that kink point each year, and you see that as the kink point moves from about $2,400 in 2007 up to $2,007 in 2009, the excess mass is moving right along with it. So if you standardize all of spending on the x-axis relative to that kink point, and you pool the data, you see this sort of 30% excess mass right of people bunching, stopping consuming healthcare right when the out-of-pocket price goes up. All right, so if you wanted if you're now hopefully convinced that healthcare spending does respond to health insurance contracts, and you wanted to think about modeling this and thinking about spending under alternative contracts, the first question to ask, I think, is how do individuals respond to these nonlinear budget sets? In particular, this was this sort of standard contract. This is the Part D contract I'll be focusing on. And there's, a large body of work in health economics that tries to ask, what is the elasticity of healthcare spending with respect to the out-of-pocket price? From the Rand health insurance experiment that I've shown you, a lot of modeling work was done to come up with this famous Rand elasticity of minus 0.2. And that's kind of treated as, a universal constant like pi given by God or someone by health economists, and papers are judged by, how close did you get to the price elasticity of minus 0.2 from the Rand experiment. But it's a little, I think, we've confused ourselves a little. I don't think the original Rand investigators were confused, but I think the subsequent, telephone game of interpreting it has gotten confused, because it sort of begs the question of like the elasticity with respect to what price, right? If you have a nonlinear budget set, the price is not well defined. And think for a moment about what would be if you had a contract without a deductible, so no initial coinsurance, and then you introduced a deductible or 100% coinsurance. What is the price change? Well, a completely myopic individual might react to as if the price has increased to 100%. They now have to pay for their first healthcare use 100% of the cost. If you have a fully forward-looking individual whose annual expenditures typically are well above the new deductible, they might not change their behavior much because the effective price they're paying on the margin for healthcare hasn't changed. So the first question we wanted to ask before we thought about modeling healthcare consumption decisions is, do these dynamic incentives matter at all? This is just, again, a testing question, or rejecting the null, of whether individuals do not react to the future price of healthcare. Reasons they might not, reasons why they might only react to the current or spot price, could be because they're myopic, they completely discount the future, they're liquidity constrained, or they might not understand this price schedule that they face. And so the empirical challenge is separating out the individual's response to the spot price and to the current price and the future price or end of year price. They often vary jointly. For example, if we introduce a deductible, that's going to increase your spot price at the beginning of the year, but it's going to also potentially affect your future price unless you know with certainty that you're going to spend beyond it. And so what you want empirically is a design in which you can vary the future price holding the spot price constant, and you can compare initial healthcare utilization for individuals who face the same spot price but different future prices. And so here we benefit from a quirk of how U.S. health insurance contracts are designed, which is, as I said, typically health insurance contracts offer coverage for a fixed annual duration, and they reset each year on January 1st. And so you get variation in the future price for individuals who join a plan midway through the year. So if you have individuals who join the same plan, but some join them in February and some join in October, they face the same initial or spot price for care, but they're going to face different future prices because the contract length differs. It's 11 months or 3 months. And so we have a nice example of this again in the Medicare Part D program that I was showing you the contract for with prescription drug coverage. So typically there's an annual enrollment period in October and November where you choose an annual plan that will start in January 1st. But there's an exception. Medicare eligibility starts at age 65, and so you can join Medicare in the month that you turn 65. Right? And so you have 65-year-olds joining the same plan, so they initially face the same spot price, but because they were born in different months of the year, they're joining at different points during the year, and so they face different future or expected end-of-year prices based on their birth month. And in fact, what we find empirically is for people who choose a no-deductible plan, because although that's not the standard contract, it is an option in Part D, the future price is declining in the join month. The later in the year you join the plan, the lower your expected end-of-year price, because you have less chance that your spending is going to get you into that donut hole where you face 100% prices. On the other hand, for people who join a deductible plan, the future price is rising in the join month. The later in the year you join the plan, the higher your expected end-of-year price, because you're less likely to have spent past your deductible. And so using this design, what we find is initial utilization responds to the future price. Let me just try and summarize that in one graph. So on the x-axis, I have your enrollment month, which is your birth month. And on the right-hand y-axis, I'm showing how the average end-of-year price varies with your join month, which is your birth month. So for the deductible plan, what you see is that your expected end-of-year price, as I said, is rising in your join month. The later in the year you join, the less likely by the end of year you've spent past the deductible, so your expected end-of-year price is higher. In the no-deductible plan, your expected end-of-year price is slightly declining in your join month. This is because there's less chance that you'll have gotten into the donut hole. And so what I'm showing now on the left-hand y-axis is the fraction who have an initial claim. So the probability you have a health care claim in the first 3 months is our measure of sort of initial health care use. And what you see is in the deductible plan, the deductible plan where your expected price, end-of-year price or future price is rising, the probability you have a claim is falling, and in the no-deductible plan, the pattern is basically flat. So these are, what you see here is a contrast, people who are joining the same plan, but in different months, so they face the same initial price, but different future prices are varying their initial healthcare spending. So to us, that's evidence that people, at least partially, maybe not fully, but they are partially aware of and responding to dynamics or the future or the rest of the budget set, and not just the current price. So now that we know that, what I want to talk about in the final part of the talk is how do we use the reduced form evidence that people respond to health insurance contracts, as well as the reduced form evidence that they're at least somewhat aware of the nature of the nonlinear budget set and responding to that, to forecast health insurance spending under alternative contracts that we don't actually see in the data or see with useful variation. And I'm going to do this in the context of the Part D program, with the starting point being this evidence that I showed you of the bunching at the convex kink created by the donut hole. And our objective here, this is based on 2 related papers with Laurent Einev and Paul Schrimpf, is to assess the response of drug spending to alternative nonlinear contracts. So an example is that under Obamacare, at least current law, this donut hole that I showed you, this increase in out-of-pocket spending in this range is supposed to be filled by 2020. And so a natural question might be, how is filling the donut hole going to change drug spending? And so what I'm going to show you is results from 2 different models, both of which by design are trying to map this reduced form bunching estimate into an economic object of interest, some kind of structural elasticity. I'm going to show you results from a static frictionless model, which is an adaptation of a model that Emmanuel Saez wrote down for labor supply responses. And then I'm going to show you results from a dynamic model. And I'm going to go through it fairly quickly. I apologize, the details are in the paper. But the key point I want you to take away as I go through the models is that these are 2 very different models, which by design match the same reduced form moment, this bunching estimator, and they're going to produce very different out-of-sample predictions. Okay, so the SIAS-style static model of drug spending is based on a very famous and influential paper of Emanuel's, which shows how in a static frictionless model of labor supply, you can translate observed bunching in annual earnings around convex kinks in the income tax schedule into an economic object of interest, namely estimates of labor supply elasticities. And this SIAS insight, along with the increased availability of large administrative data sets, has encouraged a real cottage industry of bunching estimators in labor and public finance applied to nonlinear budget sets, income taxes, pensions, fuel economy, cell phones, et cetera. And Henrik Kleven, for those of you who are interested, has a very nice recent annual review of this literature. So what we're going to do in the context of prescription drug coverage is adapt this sort of static frictionless model to our context, sticking as close as possible to the original model. So we're going to assume that individuals have quasi-linear utility over total drug spending and residual income. We're going to make up what looks like a somewhat bizarre or at least unusual set of parametric assumptions, which are chosen simply to obtain a tractable constant elasticity form of the spending function similar to SIAS. So in particular, what our function gives you is that if you had linear coverage, right, so a constant coinsurance arm, optimal drug spending is given by this equation. So basically, we're getting a constant elasticity of spending, that's alpha, with respect to 2 minus C. 2 minus C, C is the coinsurance rate. So for those of you familiar with the SIAS paper, that's very similar. We just followed his derivation to what he gets, which is a constant elasticity with respect to 1 minus T, where T is the marginal tax rate on income. So it's a very similar model, and the beauty of this model is that it allows you to derive a mapping between this elasticity parameter you're interested in and this bunching estimator B that we observe in the data, the number of people who are sort of this excess mass of people around the kink over and above the number that we would counterfactually have predicted would be there. So apologies if I went fast over that. For those of you who know the SIAS paper, it's just a one-to-one mapping from it. From those of you who don't, I apologize. But what we get out of this is an elasticity estimate of about minus 0.05. Right? So bear that in mind. If you take the bunching estimate in a static frictionless model, you get an elasticity of drug spending with respect to the out-of-pocket price of minus 0.05. Now imagine you think back to the fact that individuals aren't completely myopic, so this isn't a static problem, and you think about a dynamic model of drug use in which forward-looking individuals facing uncertain future health shocks are making drug purchases. So here we're going to think about prescription drugs as defined by this theta-omega pair, where theta is the total cost of filling that prescription, and omega is the monetized health cost of not taking that drug. So these health shocks arrive with some weekly rate lambda drawn from some joint distribution, and what an insurance contract specifies is some coverage length, T, so it's like an annual contract, and it defines a mapping, the C of theta x function of out-of-pocket costs associated with a prescription that costs theta when total spending so far in the year has been X. And the reason total spending matters as a state variable is precisely because of the nonlinear contract. So when a shock arrives, individuals make a binary choice to fill the prescription or not, and they get flow utility given as follows. If they choose to fill the prescription, they get a hit of minus C, that's the out-of-pocket spending that they have to make to fill the prescription, which is a function of the cost of the drug and how much they've spent so far in the year. And if they choose not to fill it, they get a hit of minus omega, that's the monetized health cost of not filling the prescription. Okay, so the individual's choice is to fill the prescription or not. Optimal behavior is going to be characterized by a simple finite horizon dynamic problem, and the value function is given by the solution to this Bellman equation, in which, with probability 1 minus lambda, there's no health shock, and so you go into the next period discounted by delta, that's your discount rate, with the same state variable for spending, but 1 period later. With probability lambda, you have a health shock, and then you have to make a choice. You either choose to fill the prescription, in which case you pay C out of pocket, and you go into the next period with your state variable and total spending move forward, or you choose not to fill it, and you get minus omega in sort of monetized health costs, and you go into the next period, again discounted with the same state variable of total spending to date, and it's 1 period later. Okay, so that's the individual's problem. Basically, this problem has sort of three key economic objects. There's a statistical description of the distribution of health shocks. That's the arrival rate lambda and the marginal distribution of the cost of these shocks. There's some primitive price elasticity capturing substitution between health and income. So this is this sort of distribution of omega conditional on theta. So if omega is greater than theta, if the monetized health cost of not filling the prescription is greater than the total cost of the prescription, then the individual is going to always fill the prescription, even if they have to pay the full cost. But if omega is less than theta, they're going to fill it only if some portion of that cost is paid by the insurer. What portion they're thinking of and what features of the contract they're thinking of depends on the extent to which individuals understand and respond to the dynamic incentives in the nonlinear contract. That's captured by this discount rate delta. Sort of full myopia or delta equals 0 would mean you wouldn't fill the prescription and, if the monetized health cost of not filling it is less than the current spot price or out-of-pocket price of filling it. If there's a dynamic response as delta greater than 0, which we would expect given the reduced form evidence, then utilization would depend on both the spot and future price. Obviously, this delta parameter is not some primitive time preference parameter. It's context specific. It captures salience, discounting, perhaps liquidity constraints as well, but it's a sort of reduced form way of capturing the extent to which you respond to dynamic incentives. So to estimate this model, rather than in the Saya-style context, a simple mapping using the theory from the bunching estimate to the parameter of interest, here we're going to have to sort of do more. We're going to have to parameterize the model with distributional and functional form assumptions. We have to model heterogeneity. We do it using a discrete type space. We estimate this using simulated minimum distance. And among the moments we fit, we include this excess mass or bunching at the kink, so this sort of histogram of total spending around the kink. And given that we set up the model to fit it, by design we fit it. This is the observed and predicted fit of excess mass. Okay, and so once we have this model, we can do a similar exercise to get an elasticity estimate. We're going to consider a uniform % price reduction on all arms of that standard contract, simulate spending for each individual under the original coverage plan and the modified plan, and use these to compute elasticities. And this is going to yield implied elasticities of around minus 0.25, so about 5 times larger than what we got from the static model. Okay? And so that's in some sense the key point I wanted to emphasize. If you compare the static and the dynamic approach, both of these are matching the same reduced form fact, this bunching or excess mass around the kink by design. They're both designed to do that. And yet, so we can both, sort of match the data, but they're going to deliver very different elasticity estimates. As I said, the dynamic model elasticity is about 5 times larger than the static model. So, the point, again, which is hopefully neither particularly novel or particularly controversial, is that modeling choices have consequences. So again, if you think about the recent sort of interest in use in sufficient statistics, which offer the possibility of taking reduced form moments in the data, like the bunching estimate, and mapping them to an economic object of interest, the key point is the statistic is sufficient conditional on the model, and which model you choose can matter. Now, I want to emphasize these models are, first, they're conceptually different, and they're not nested, right? So the Saya's model is frictionless. The implementation allows for some friction since the bunching is measured, with some bandwidth. You don't literally look right at the kink. The dynamic model, though, explicitly allows for lumpiness by modeling a discrete series of weekly health shocks and purchase decisions. Perhaps more importantly or more interestingly, the Saya-style model is static. So you're thinking about all uncertainty realized prior to any spending decision. So in the original context in which that was developed for an individual's labor supply decisions, that's perhaps not an unreasonable approximation. Individuals at some frequency, say once a year, make a decision of what job to take and how much to work. But in the context of healthcare choices, right, in the dynamic model, individuals are making sequential purchase decisions throughout the year as information is revealed. And so this model allows for anticipatory behavior, and indeed we find that. We find that the set of people at risk for bunching are endogenously affected by the presence of the kink, Or put a different way, in our counterfactuals where we fill the donut hole, which is supposed to be done by 2020, and ask how is that going to affect drug spending, that obviously affects drug spending for people who under the original contract were going to be right at the kink in the donut hole. But we also find it affects drug spending for people who in expectation were spending far less than the donut hole, and that's because those people are endogenously reducing their healthcare spending because they realize there's some chance they might get a shock that would put them in the donut hole if they spent a lot more. And so by contrast, the static model by design is going to miss any of this anticipatory or dynamic behavioral response outside the bandwidth that's used to measure the bunching. It's looking at the response just right at the donut hole. The other thing I want to emphasize about these two models is that they're not vertically rankable, right? The SIA-style model has the real virtue that it provides a simple and transparent mapping from a descriptive fact to an economic object of interest. The power of that model, which I went through very quickly, is that it allows you to map directly from the bunching estimator and the cost-sharing parameters to this elasticity of interest. And relatedly, it can be implemented quickly and relatively easily. So if you wanted to do this across a bunch of very different contexts, you can take the same sort of off-the-shelf model and apply it easily. By way of reference, this, once we had the data and the basic reduced form up and running, this took us about 2 days to do. The dynamic model took us another 1.5 years, which may speak as much to our deficiencies as the models. But the dynamic model, it's more computationally challenging and time-consuming to implement. Perhaps more importantly, because probably the social value of our time is not that high, it's much more black box in terms of the relationship between the underlying data objects and the economic objects of interest. We try in the paper to talk about what the key moments are and what's driving what, but at the end of the day, it's a much more complex model, and so there's not a simple mapping from one reduced form object to one parameter of interest. But its advantage is that it can account for potentially important economic forces that a static model abstracts from, such as, for example, these anticipatory responses, that the impact of filling the donut hole is not limited to people who end up at the donut hole. All right, so what I want to do in the time remaining, having sort of given you a whirlwind tour of existence, nature, and implications of moral hazard, is return to the theme that I mentioned at the beginning and ask, why do we need reduced form evidence? Where is that valuable? Where is economic model valuable? And where are there important complementarities between the two? So let's start with, the value of reduced form evidence. I think it's invaluable for testing and trying to reject nulls. For example, the Malcolm Gladwell null that there's no behavioral response to health insurance, or the health policy null that health insurance, will reduce healthcare spending rather than increase healthcare spending. So if you just, if you're just sort of, want to, test these sort of competing views, I think there's no better way to do it than a compelling reduced form, either randomized or quasi-experimental design. It's also useful when the policy of interest is actually captured by the reduced form variation. So a natural example would be retrospective analysis. For example, if you wanted to know what happened when Oregon expanded Medicaid coverage in 2008, or for historical analyses, for example, work I've done with co-authors on saying, what was the impact of the introduction of Medicare in 1965? If you're interested in retrospective analysis and that you happen to have reduced form variation for what you're interested in, it can be extremely valuable. It can also be valuable when you're doing prospective analysis that's close enough to the experiment. So for example, the 2014 expansions of Medicaid under Obamacare in the United States covered basically a very similar low-income adult population as those who were covered in Oregon under our experiment. So, of course, a key factor is, what factors matter for closeness? Is it enough that the populations are similar, the economic climate was different, the healthcare arrangements in different states are different, and that's where, again, ideally, theory would be useful in guiding what is closeness. But those are some, I think, incredibly valuable aspects of reduced form evidence, and why sort of you probably always want to start with it. Why then do we need economic models? Well, I gave you one example today by focusing on the question of if you want to do counterfactual analysis of spending under contracts not observed in the data. So for example, the results from the RAND health insurance experiment that I showed you are regularly used in a US health policy to forecast spending under other contracts. For example, what would happen in a high deductible plan? What would happen if we changed cost sharing? But as long as you're thinking about plans that are not literally the plans in the experiment, you need some economic model to how to go from the treatment effects in the experiment to these out-of-sample forecasts. So what the experiment gives you is basically the treatment effects of about 4 or 8 different plans. These plans themselves are nonlinear, so if you want to think about forecasting spending under alternative plans, you need some economic model of how individuals were responding to these plans to take it out of sample. Or similarly, as I gave the example of spending responses to alternative prescription drug contracts, such as reduced cost sharing or filling the donut hole. That's what I've talked about today in the interest of time. I should mention there are several other important roles for economic modeling that I haven't had time to cover by way of examples. One incredibly important one is if you want to do normative welfare analysis of reduced form results. So for example, the Oregon health insurance experiment, I showed you some results today on healthcare spending. We've also shown impacts of Medicaid on improving some aspects of health and on reducing economic exposure to risk. How do you take those results, their costs of expanding Medicaid in the form of increased healthcare spending and their benefits in the form of improved health and reduced exposure to risk or improved consumption smoothing? How do you put that together and say on net, what is the welfare value of this policy and how does it compare to the cost? Well, if you don't want to do this in a completely ad hoc manner, you need some formal economic modeling of the utility function to map these reduced form estimates into some normative object. Another key use for economic modeling, which I haven't covered today, of course, is if you're actually interested in recovering sort of structural primitives of interest. For example, the individual's marginal rate of substitution between consumption and health, you want to use these reduced form objects to uncover these sort of more deep or structural parameters. But the main thing I wanted to talk about is complementarities, like how these two forms or two approaches can be used together to add value. And I want to give 2 examples. So one, I think, is simply more bang for your reduced form buck. We often want to know the impact of a policy, past or present, where we don't have direct reduced form evidence. And so as I said, the model helps get us from the reduced form to that out-of-sample prediction, such as what would spending be once we fill the donut hole in Part D. The other thing I think, the other way the complementarity runs is the other way that the reduced form evidence can really help guide what we should be modeling and how. So the reduced form evidence helps focus our questions. If you're going to embark on a research agenda of modeling spending responses to alternative nonlinear contracts, you'd feel a lot better, or at least I would, is if you had confidence that moral hazard in fact existed, if the phenomenon you're trying to model is actually empirically there in the data before devoting substantial effort to thinking about how to model it. So having rejected the null of no behavioral response or the opposite sign behavioral response, sort of motivates you to go ahead to the next step of the modeling. And probably, as or more importantly, the reduced form evidence can help guide our modeling choices. So as I showed by way of that static and dynamic model, these different models can match the same reduced form objects and have very different implications out of sample. How do you pick among the models? Well, some of it is about transparency and ease of implementation, but at some deep level, it comes down, if you have time on your hands to do the more complicated one, it comes down to, is it worth it? Does it make sense? Right? The fact that we had reduced form evidence that individuals are in fact forward-looking, that they do take into account, at least to some extent, the entire nonlinear budget set, and in making current healthcare decisions are responding not just to the current or spot out-of-pocket price, but the expected or future end-of-year out-of-pocket price, made us feel that we didn't want to stop with the static model, and despite the additional work and effort, you could get quantitatively different implications from a dynamic model. So I think, again, whether that added complexity might be worth it can be highly motivated by sort of these basic reduced form evidence. So let me just wrap up here with some concluding thoughts. I mean, my basic conclusion is I think this is just, I feel incredibly lucky. This is a really great time to be an empirical economist. There's a rich tradition of economic models and structural estimation to draw on. We have improved and constantly improving reduced form toolkit for identifying causal effects. This is this credibility revolution. And there's increasingly rich data, especially administrative data, on which you can fruitfully use both of these approaches. And there are incredibly exciting and valuable opportunities from combining these individual valuable strands. In some sense, you can think of some super modularity in combining approaches, and hopefully we'll see more of this type of dialogue between the two approaches, both within individual papers and across papers going forward. So thank you very much.
So I believe it was not foreseen that we would have time for Q&A, but given that we have 5 more minutes, it seems valuable if any of you wants to ask a question or have some discussion, maybe to take advantage of Amy's presence here. And by the way, thank you, Amy, because it was a really insightful lecture. Any questions? Yeah.
Oh, thank you. You went too fast on your model for me to understand it full. I believe that you presented a model where you have this Poisson process. So it means...
I can't hear you.
So you have a Poisson process. It suggests to me that it's temporary shock to your health, not permanent. So did you try something with the Brownian motion where it would be more like modeling for a chronic disease rather than a temporary shock to health?
So I had a little trouble hearing the question. I think you asked that we have a sort of Poisson arrival process of health shocks, and how do we think about chronic disease? Okay, so first of all, let me apologize for going quickly through the models. I sort of felt that in the time available to cover a lot of things, one couldn't do any of them justice. So I tried to give you a flavor for it. You can look at the papers for more detail. To answer your question, we allow for heterogeneity in the type space, so we have sort of 5 different types, and you can think of people with chronic diseases having a higher arrival rate of shocks each week. So most people, even in chronic diseases, don't have prescriptions they have to fill every week. At most it's monthly or something like that. But you can think of someone with a chronic versus an acute disease as someone who faces a higher arrival rate of shocks, and that would be the way to think about it. But the model is obviously, as all models are, an abstraction from reality. It doesn't, model everything. For example, a big issue in the United States is the choice of prescription conditional on filling a prescription. Do you fill the branded version, which is much more expensive than the generic version? There are many features like that we abstracted from, hopefully to get at some core basic ideas. But it certainly does not, it's not a complete model of the healthcare decision process.
Other questions?
Yes, I was fascinated by the response of emergency room visits. Can you explain that using any model that's at your disposal right now?
Sure. This is a great question, and one that comes up a lot. The question was, how can you explain the increase in emergency room visits? So the thing I should have been clear on is that in the United States, the law is you have to treat anyone who comes into the emergency room regardless of their ability to pay. You don't have to do that in other settings, but you can charge them, and they are charged for it ex post. Now, there's some question of how much people end up paying or whether they have unpaid medical debt. But I think once you know that, the economics of it are very simple. Medicaid makes the emergency room free, so the own price effect says that when you make something free, people are going to use more of it. Now, the reason it wasn't totally crazy to have this hypothesis out there that Medicaid might decrease emergency room use is because of the cross-price effect. Medicaid not only makes the emergency room free, it makes primary care free, right? And so, as we showed, primary care also increases. If primary care and emergency room use are substitutes, And it's not clear, by the way, they are. There's a theory out there that they're actually complements, because I'm more likely to go to the emergency room if I believe I have coverage for whatever illnesses are found in the emergency room that need subsequent care outside of the emergency room. But if they're substitutes, then the cross-price effect says that when you make both of them free, people might substitute out of the emergency room and into primary care. The experiment is not designed in a way that allows us to estimate that cross-price effect. It may be there, and it may be, it may be that the primary care and emergency room are substitutes. What we can say is that any such substitution, if it exists, is not large enough to dominate the own price effect, and that's why emergency room use is going up.
Okay. There's a question there.
So thanks to your talk, we know that moral hazard exists, and you have shown that very nicely. You have also talked about the potential welfare costs that this cost sharing also includes. So we would only like to basically have cost sharing and impose those costs to people if moral hazard is really there. So is there any evidence on heterogeneity of moral hazard? Is it there in every situation? Are there other ways to make people internalize better the cost they cause to the schemes?
Sorry, say that last part again. Are there other ways?
So first of all, is there some heterogeneity in the evidence of for moral hazard? Is it there in all the situations? So you have talked about drugs, for example. I mean, there is a heterogeneity between inpatient, outpatient. So first of all, is there is moral hazard there in all the situations? And do you know of anything, of any other ways also to make people internalize the costs that they cause to the scheme, to the insurance scheme?
So you're asking a very good and very hard set of questions about optimal insurance design. Another way of saying it is these moral hazard estimates are only one input into optimal insurance design. You want to balance that against the consumption smoothing benefits, which one has to separately measure, and then you want to think about, in comparing consumption smoothing benefits and moral hazard estimates, is there heterogeneity across people or types of diseases, et cetera? So the optimal contract may be different depending on the nature of the person or the nature of the healthcare coverage. And then your other question was, are there other things, do we have any other instruments at our disposal other than cost sharing? So on the first, there's certainly evidence of heterogeneity, both across types of care and across types of people. Just as one example, in work that Laurent Enev and I have done with Maria Polyakova, we've estimated, using that bunching estimator, sort of differential response, price elasticities of demand for different types of drugs. And so you might think that when demand is more elastic, when there's more of a moral hazard response, you should set higher consumer cost sharing, and if demand is less elastic or completely inelastic, you can have more comprehensive coverage. In practice, public drug insurance programs, both in the United States and in Europe, tend to set a uniform cost sharing rate across drugs, despite that heterogeneity, although in private health insurance plans in the United States, they tend to vary the cost sharing in the way that would be, considered optimal by that basic theory. And there's certainly work that can be done looking at that type of heterogeneity. On the question of do we have any other instruments in our toolkit other than exposing individuals to more risk to reduce moral hazard, the answer is yes. You get into the fascinating, rich, and complicated area of provider-side incentives. Everything I've talked to you about today is about consumer-side incentives. The other way to try to efficiently deliver healthcare is to think about the incentive from the provider point of view, and then you get into issues of having providers or groups of providers be the residual claimant on the healthcare spending of all their patients, as opposed to being reimbursed fee-for-service for everything they do, and the trade-offs there, once again, between insurance and incentives, but now on the provider side. And that's a whole other rich and fascinating topic on which I think there's active and important work being done.
Okay, so let me ask you one last question.
Okay.
If you could design the next Oregon experiment, what would that be like?
So that's a great question, and I'll say that I probably, following up on the question that was just asked, I'm increasing, I mean, it depends what you're interested in, but if you're interested, as many of us in the US are, on how to efficiently design healthcare delivery, I'm increasingly convinced that the major issues are not actually on the consumer side, but on the provider side. If you just think about that nonlinear contract I put up, right, where you have these stop losses if you spend enough, healthcare spending is extremely right skewed. The top sort of 2% of people account for something like, I forget the exact number, but 25% or more of healthcare spending. And so if you're really concerned about the efficient delivery of healthcare spending, most of the dollars are being spent on the people who are in the stop loss, where so consumer cost sharing is not what's important, but presumably provider incentives are. And so I think the dream randomized evaluation would be something on provider incentives. Now, one often gets pushback that that's hard to do, both for political constraints and also because at that point the level of randomization is not the individual or even the individual provider, but presumably a group of providers. And we've been extremely fortunate. We just learned recently that the Obama administration has run this randomized evaluation for us. They have they did a randomized evaluation at the city level of a bundled payment reform, which for lower extremity joint replacement, so that's like hip and knee replacement. This is in the Medicare system, and basically what that means is instead of the hospital being paid to do the operation on the patient, and then the patient goes home or to a nursing home, and the nursing home gets paid, or the rehab center gets paid, they're putting the hospital on the hook for the whole 90-day episode, including the sort of 5 or 6 day hospital and the subsequent downstream rehab, and setting a target price and giving the hospital bonuses or penalties if the total 90 days expenditure exceeds that, to try and give the hospital incentives to coordinate the downstream care efficiently, get people home faster, not in rehab if they don't need it. And they randomized this at the MSA level. It's been going on for 2 years. The Trump administration just announced last week that they're probably stopping it, but it turns out 2 years is enough for power, and their randomization protocol and which cities were randomized into treatment and control were published in the Federal Register as sort of a public document. And so we're going to be able to study what the impact of system-wide payment reform is on healthcare spending. And so I think those kinds of randomized evaluations on the provider side are what I'd love to see a lot more of.
Excellent. So we stay tuned for more.
Okay.
Thanks a lot, Amy.